Good afternoon, all. Welcome all the panelists for joining us today. Today, we are going to do a live online virtual interactive discussion on COVID and about the coronavirus. All of us know that humanity is under crisis, and a lot of countries are really struggling with this current issue. Like India, we are all preparing to face certain difficult situation in the future. So today we will have a discussion based on some of the available evidence available in various official resources. I'm going to introduce our panelists first. We have got Professor Mohammed Rela here, who is an liver transplant surgeon. He is also a chairman and managing director of Rela Institute Medical Center. Thank you very much for joining us, Prof. We have got Dr.
Thank you. Welcome.
Dr. Naresh Shanmugham here is a pediatrician. He's also a director of hepatology, also pediatric hepatology. He's also a director of women and children at Rela Institute Medical Center. Welcome, Dr. Naresh.
Thank you, Doctor.
We got Dr. Ravi Kumar, who is a pediatrician who has been very active in setting up our center to receive our patients in case if we have any patients with COVID. Welcome, Dr. Ravi. We got to Dr. Vidya, who is an infectious disease consultant. Dr. Aishwarya is a pulmonologist. We got to Dr. Shubha, who is a microbiologist at Rela Institute Medical Center. We got to Dr. Jimmy Prabhakaran, who is a general medicine consultant. He is also the nodal officer from our hospital, who is representing our hospital to the government of Tamil Nadu. We got to Dr. Dinesh Jyothimani, who is an hepatologist and also a liver transplant physician. Thank you, Dr. Lalita Sundaraman, for joining us. She is an anesthesiologist and intensivist from Boston, USA. Thank you very much. I think it's 4 o'clock in the morning in US. So thank you very much for joining us. We got to Dr. Satya Cherukuri, who is a psychiatrist consultant from Scotland, UK. Thank you for joining. We got to Dr. Akila Rajakumar here. She is an intensivist and anesthetist. She is also a chief quality medical officer at Rela Institute Medical Center. We are supposed to have two more panelists. They couldn't join because of some other medical reasons. We can continue with our panel discussion. I'm going to start with a little bit about the history of pandemic. Dr. Vidya, what is a pandemic? What's the difference between an epidemic and a pandemic?
Yeah, pandemic is something that's affecting the entire population across many countries. It has no boundaries. So that is what is a pandemic, like the pandemic that we're facing now of COVID, the SARS pandemic that we've seen earlier, multiple flu pandemics that we've seen earlier, or say we've come across the Justinian plague, or the bubonic plague that we've seen, which took away, say, 200 million lives earlier. So these are pandemics which go across many other countries and continents, affecting a huge lot of population. So that exactly is actually a pandemic.
Is there any definition like how many countries should be involved before declaring pandemic, or how many patients should get infected? What about the previous SARS and MERS? Were they announced as a pandemic?
Yes, actually SARS was a pandemic. However, MERS actually was confined to the Arabic Peninsula. But if you also look at Ebola was confined to actually the Africa and Sierra Leone. So they were across just a few, defined territories, unlike SARS, which crossed many countries and borders.
Okay. So in today's discussion, I just wanted to show a nice video I have seen in YouTube, which describes what are all the previous pandemics, how the mankind has suffered because of the previous pandemics, how they have coped up in the last 1,000 years. The pandemics are not new to the world. There are many pandemics where millions of people died. And I think it's interesting to note that always mankind has coped up with the situation, and we have always bounced back. I think that's an importance of handling this kind of situations. So I'll play the video now. So this will show how the history of pandemics evolved over many centuries. So this is Antonine plague, occurred in early first century, 165. That's in AD 165. Almost 5 million people died, which was followed by plague of Justinian, occurred in 541. Almost 30 to 50 million people died, followed by Japanese smallpox. And then this is the worst, one of the worst pandemic, bubonic plague. Almost 200 million people died. And then in 15th century, 56 million people died because of smallpox. In 17th century, 3 million people died because of great plagues. In 18th century, 600,000 people died because of great plague. And then cholera came into picture. Millions of people died because of cholera. And then plague again started to play a major role, followed by yellow fever and then Russian flu. This happened in the last century, in the 19th century, Spanish flu. 40 to 50 million people died because of this. And then the last 30, 40 years, Asian flu, Hong Kong flu, where millions of people died. And then AIDS came into picture. Until now, 23 to 35 million people dead over the period of time. The last 10, 15 years, we have seen swine flu, where 220,000 people died because of swine flu. Ebola, 11,000 people died. SARS, 770. So this is a history of overall death toll of the plague or other pandemics in the last 1,000 years, which has affected the world. Now, unfortunately, in our lifetime, we have to face one more pandemic. I think there are some positive signs and a lot of negative signs are there. I want to show one more slides, and I'm going to ask one question to Professor Rela. This is the current trend of number of patients with COVID, Prof. What do you think? What will be the trajectory in India? What's your view about this?
Thank you, Ilan. The trajectory, I can't see it properly. The India is, which color is that?
India is orange.
Orange, yeah. It's not South Korea. But if you just look at the trajectory, it doesn't look too good, actually. But I've always had a positive note about India. I think that India might just escape, but I don't want to be too optimistic too early as well. I don't want this to be quoted. India is going to get away without major problem. But there are many reasons. I think over a period of time we can discuss over a period of time what that is. Even though the first cases in India were actually reported in the end of January, I think on the 29th of January, at a very similar time to the United States, our numbers have actually not, because this graph is from the beginning of the 100th case, isn't it? Not from the first case reported.
Yeah, that's right. Yeah.
Yeah, it's from the beginning of the 100th case, because by the time we reached the 100K, people who started with us were much ahead of us. So I'm not so sure. If you look at the graph, it does look worrying to me. But I somehow feel that we'll be a little bit better here than in India than in any other part of the world. We can discuss the reasoning behind. There are many reasons behind. I mean, one of the reasons I've always suggested was I've lived in the UK for many years. And when you look at seasonal flu, I mean, which is also kind of it's a viral infection, influenza, it doesn't affect the Indian population as much as it affects the Western population. People still claim that temperature is not an issue, and places with high temperatures may not escape this, but that is really, we need to wait to see. But certainly what I've seen in the last month is the severity of illness in India has not been as high as actually in the Western world. And the mortality figures, I believe, are also going to be much lower in India compared to the Western world. I mean, this is really my personal view. I can't back it up, and only time will tell whether I'm going to be right or not.
Perfect, Prof. I think when we look at the graph, I'm sure we will appreciate that we are not the first country to get affected. The countries which have got the infection earlier on, like China or Italy or other countries like Spain, we have seen a lot of people getting admitted, and the mortality rate is also pretty high. But I'm sure we are slightly in an advantage position here, because whenever a disease comes to our place a bit later, there is enough time for us to prepare ourselves to handle any kind of situation. The second advantage is we may be able to understand the disease better. I'm sure there might be a lot of treatment options will also be available in the near future, because last 3 months, 4 months, there are a lot of studies and a lot of reports came out from the area where this disease has affected the most. Will be really useful when we started to receive the patient. I'm sure all of the doctors in this group will agree that as of now, the major positive point is by speaking to our colleagues, patients are not flooding to the hospitals, and there are not too many patients in the intensive care unit with COVID-like symptom. I think that's a major positive point at this point of time. But we have to wait and see.
Can I interrupt? I think you made two important points here. One, I said we are not getting many sick patients. I think the Indian government has actually acted pretty early in shutting it off for really foreign travel into this country, and they've also shut the states and isolated everything. I think they've been more proactive than most of the Western world. Right or wrong, I think it is right personally. I think persisting on this is going to help hugely. The second biggest advantage that we have that you mentioned, I think it needs to be pointed out, that if we do get into trouble, who knows, we may have better options. The first thing is what the Americans call flattening of the curve. So the health system is not inundated with huge volumes of patients all at the same time. But also we may have some advantage in understanding the disease and may be able to even better cope with the illness as patients come in. So it is an advantage to be at the far end of the graph, where our peak, if it comes a little later, maybe 1 or 2 months later, we may be able to understand the disease better and manage the patients better than what has happened in the Western world.
Yeah, thank you, Prof. I think the trajectory can go in two directions. One is we might end up the situations like what's happening in US or Italy or Spain. The other option is we have to face this pandemic for quite a longer period of time, maybe 6 months or 1 year or 18 months. If you look at the other pandemics history, those kind of pandemics has stayed back for many years. So it might not disappear within a few months' time. So this is the direction we wanted to have our discussion for the next couple of hours. So what I'm going to do is we'll move on to our current issue. So I want to show one more slide now. Actually, I missed that slide. Okay. So this is a question for all these Facebook viewers. Could you identify what it is? You can reply back in the Facebook. I'll give 30 seconds time. You can type it in the Facebook. If you can recognize what it is, I can give you a clue. This is worse than coronavirus, which is the culprit of majority of the pandemics in the world where people died. Dr. Shubha, can you identify?
Plague, obviously. Yeah. You've given a clue, the biggest killer.
Yes, it's a killer, biggest killer. So this is Yersinia pestis. This is a bacterium which has caused a plague and many people died. So I thought before moving on to our current villain, the coronavirus, I thought I will show you the previous villain which has caused the major problem in the world. I have got one more interesting slide. We are talking about quarantine, and people shouldn't think that we have invented the quarantine. If you look at the history here, quarantine was introduced in the 13th century in Italy. So when the patients were affected with the plague, when the sailors were affected the plague in the ship, the government ordered them to stay in the sea on the ship for 30 days. They called it as a Trentino. And then later on, they realized that 30 days are not enough. So they increased the days of forced isolation to 40 days, which was called as quarantino. So the same terminology, the quarantine, has been adapted by the West, and we are using the same word quarantine nowadays. Of course, we are not using this 40 days isolation. So even if there is 1 or 2 days isolation, we call it as quarantine. But people have realized why this isolation is so important, why people should follow this social distancing and isolation. Now, even in the 21st century, we have to understand, and then we have to strictly follow all these things. Only those kind of isolation has helped in the past. Even if you look at last 3-4 centuries, whenever this pandemics happened, only the self-isolation has helped when you look at the history. I think this is an important lesson for us to learn from the past. Dr. Vidya, can you describe a little bit about this coronavirus, the bad boy?
Coronaviruses, you actually have alpha coronaviruses, which can cause cold or common fever. Whenever we do a respiratory viral panel, about 22% of it can actually be coronaviruses, which are the alpha coronaviruses, where you have HK22 and maybe you have NL63, etc. But you also have what is called as the beta coronavirus, which is HKU1 and I think OC43. And these ones, that is this particular novel coronavirus, the MERS coronavirus, is supposed to be the beta coronavirus. And even the SARS and
Vidya, what you're speaking is echoing a lot. Would you come closer to the mic? Maybe even open the door. I think it's a very closed door that you're sitting close room.
Just a minute, sir. I'll open the door.
Open the door, it might reduce echo. Sorry.
Okay. It's actually called a coronavirus because it's crown-shaped and it also has something like the spikes of the sun. And this coronavirus actually seems to have originated from the bats or the pangolins. Okay, and it had a mutation, and that's why it actually caused disease in humans. So when they stay in the bats, apparently they don't really cause symptoms. And these viruses mutate and change over time, and they really can't be predicted. Apparently the ones and they evolve over time. The ones in Wuhan and the ones that caused the outbreak were the L strain, which were more virulent. And subsequently, they also found the S strain, which was supposed to be less virulent, and it emerged in the later part of the outbreak outside Wuhan as well.
So, Dr. Vidya, how will you compare the current pandemic to the previous pandemics in the last 1 or 2 decades, like MERS or SARS or other flu-like illness? How would you compare?
Yes. So I think if we have to talk about this, I should go into something which is called as R0. So if I can just brief the audience on what is R0. Okay, R0 is something which is called as the basic reproduction number, which means to say an average number of people that the virus can actually infect from one contagious person. Okay, that is called as the R0. And say if the R0 is more than 1, that means the epidemic is going to increase exponentially. If it's less than 1, the epidemic will burn out. And if it's equal to 1, the epidemic will usually tend to remain in a steady state. So this is what. So now what are our usual R-naughts of the previous epidemics? Say H1N1, the R-naught of this epidemic was somewhere between 1.4 to 3.8. But the novel coronavirus, the R-naught is supposed to be, initially they thought it is something like 2.5, but we had a publication in the EID yesterday saying the R-naught could be anywhere up to 5.5, which means it can spread quite fast, quite exponentially. The transmissibility of this virus is quite high. Despite containment measures, it's going to like spread it's quite infectious. And the other thing is, see, if you look at the risk factors, if you look at influenza and the coronavirus, the risk factors, it still affects children, pregnant people, and elderly. That's the influenza. Whereas here, it could be children apparently happen to be getting infected from the adults. And the severity of the case fatality rate of influenza seems to be slightly lower. It's supposed to be 0.1. Whereas here, when you look at COVID, the case fatality rate is about 3 to 4%. You have vaccines available for influenza, which have an effectiveness of at least 70%. Whereas if you look at novel coronavirus, I think all this is still in the mix. And you have a lot of pre-symptomatic shedding, asymptomatic shedding, and a prolonged shedding of virus, which makes it very difficult to contain.
Yeah, thank you, Dr. Vidya. So what's the big difference between common cold, where people get at least 4 to 5 times a year, and then this flu? What's the big difference in terms of mortality rate and R-naught and whatever it is? How do you...
In COVID, the mortality rate is about 4%. Or in flu, it still can be 0.1%. And in SARS, mortality rate is about 10%, and in MERS about 34%.
Okay. So what
Vidya, can I just interrupt there just to summarize what you've said? You've said the R-naught for COVID now is much higher than the...
Yes, sir.
In the range of 4%, you've said. And the reason for that, the reason for that is for most viral illnesses, more when they are actually symptomatic, so you can just hide them away. I mean, there are some viruses where they can be symptomatic in the prodromal time, but here there are many patients who are infective when they are asymptomatic or when they are going to get symptoms a few days in the prodromal phase. And
Yes.
that is probably why the R-naught is so high, because people get infecting other people before they know that they've got the disease.
Absolutely.
Isn't that the
Yes.
summary of what
in the pre-symptomatic, mildly symptomatic phase, also they shed the illness. Asymptomatic phase, also they shed the virus.
That's why the R-naught is so high.
So high.
Okay, thank you.
But the R-naught will vary when the pandemic progresses.
Yes.
Dr. Vidya.
The
So what
best
happens is
way-
I have read an article from ICMR which says that there is a possibility that one person can infect up to 40 other individuals when they come out to the community. But you are saying that the R-naught is only up to 4 as of today.
5 point something. The
So
best.
say 5 or 6. But what's the difference? Do you think once the pandemic, at this point of time of pandemic, where we are at the initial stage, the R-naught may be higher, and over the period of time that will reduce, or what's your view on it?
The best way to establish an R-naught is when the epidemic or the pandemic stabilizes. Okay, and this is an average number. This what we get now will be an average number, and definitely social distancing has an influence on the R-naught.
Okay. So
Social distancing reduces R-naught.
what are the clinical presentations? We know that that can cause flu. But what have you seen? What's a normal clinical presentation?
Yes. So actually, if you really look at the clinical presentation, it comes out of very important lessons that we learned are from the Chinese CDC that they presented. Most 81% of the patients actually have mild symptoms, and about 15% of them have severe symptoms, which means to say they can have dyspnea, respiratory, increased respiratory rate, hypoxia, which they actually called as silent hypoxia, or lung infiltrates, and only about 5% would be critically ill. Definitely the ones with comorbidities, say 10.5% of the patients with cardiovascular disease, about 7% with diabetes, 6.3% with the respiratory disease will have increased mortalities or increased case fatality rates are high in those patients. So what if we really look at the common symptoms that they present with, commonest symptoms from various studies in NEJM, Lancet, etc., the commonest symptom that they present to us is fever, anywhere ranging from 60% to 80% of patients present to us with fever, followed by dry cough, which is the second common symptom. About 5% of them can present to us with productive cough or sputum production. And the next common symptom is fatigue, and followed by dyspnea is, again, I think this graph probably has a slightly decreased, I think it's a 20% dyspnea, but I think it can go up to 40%. We can have dyspnea as a presentation. Diarrhea is about 4%, but we do have a recent publication from American Journal of Gastroenterology. Patients which studied about 208 patients with mild symptoms, out of which 48% had only diarrhea at presentation. About 69 had diarrhea with respiratory symptoms at presentation. So somebody with contact with COVID can present to you with only diarrhea and absence of respiratory symptoms. So we need to keep that as one of the screening tool as well.
Yeah, thank you, Dr. Vidya. So when should the patient approach a hospital? Dr. Jimmy.
Can I interrupt there, because it's focused so much on the diarrhea? Can I say, Vidya, that is there a possibility of a fecal-oral infective route?
Yes, sir. They have reported fecal-oral transmission as the other possibility of, apart from respiratory transmission, which is the most commonest route, and apart from the fomites, fecal transmission has also been hypothesized.
So the patients who are suffering symptoms have to have separate toilets, or people have to be very careful about the hygiene?
Yes, yes.
Okay, all right.
Yeah, Dr.
Can I ask one more? Can I say one more?
Yeah, sure.
Not to frighten everybody, because in the statistics you said 85% of the patients have very few symptoms, and 15% have actually symptoms which might require hospitalization. That is actually a scary. It's a scary statistics. The way I look at it, we are saying actually, if you look at Italy, the mortality is more than 10%. In the UK, it's more than 10%. Maybe they are not testing everybody in the population, but in those who are tested, then the in-hospital mortality is extremely high. So if a patient, only 15% of the patients have to go to hospital, that means if 5% are dying, a third of the patients who are admitted to hospital are going to die. Isn't that a frightening statistics? Is that true?
I think that's true, Prof, actually, because even when I was speaking to our friends in UK, they say that if there are 400 patients in the hospital, almost 100 patients are in the ICU. Almost 1/4 of the patients are in the ICU. Even if you look at the report from ICNR, that's an UK ICU body, they say that almost 50% of the patients die once they go onto the ventilator. I think the statistics seem to be the right number.
But that's very frightening, isn't it? You don't expect 50% of the patients going on a ventilator to die.
That is frightening.
And if that is the case in the Western world, the ventilator death in our country is going to be even much higher.
That's true. I think that's an advantage of having a slow pandemic. For example, because of this lockout period or extension of the lockout period, we can't say that we will not avoid this pandemic completely, but actually we can slow this pandemic a little bit down, which instead of having this pandemic a spike within a month, we can extend this period over the period of time, so that the number of sick patients approaching the hospital will be less at the single point of time, and we'll be having enough resources to handle only a small number of patients. Say instead of having 1,000 patients in Chennai or in a city like Bangalore in a given day on ventilator, there's no way we can cope up with that scenario. At the same time, if those 1,000 patients come with an interval, like over the period of 1 month or 2 months, I'm sure we should be able to handle it, and the outcome may be slightly better compared to having a big spike of patients.
Okay, thank you.
So just to add on a few more atypical or a few more clinical presentations, I think about 8 to 12 can present with cardiac manifestations like say arrhythmias or carditis, viral myocarditis. And then we do definitely have to look for CNS manifestations, about 30%. Of them, the ones who have severe presentations do look out for strokes or, embolic phenomenon. That's another thing that we'll have to look out for.
Yeah, thank you, Dr. Vidya.
The severe group.
Yeah, I have got some questions. People have started asking questions on Facebook. And then we also have a WhatsApp number. The number is 93846-81770. We have already made an announcement. We are getting questions to this number. So the first question from the public is, when should they approach the hospital? How will you differentiate a normal flu and then coronavirus? It's quite common to have an fever-like symptom and bit of cold and cough. Should they come to the hospital straight away? Dr. Prabhakar, what's your advice to the public?
Jimmy, you're muted. You're muted. You're not heard. Can you unmute yourself before you speak?
Yeah, Dr. Prabhakar, can you speak?
Yeah.
Yeah.
Audible, sir?
Yes, you are audible now.
Yeah, yes. So we categorize the symptoms in the background of fever more than 38 degrees, lasting for more than 3 days. And the symptoms is major criteria and minor criteria. So major criteria is usually cough and breathing difficulty, a loss of smell, recent onset of loss of smell and taste. All these three is the major criteria. And minor criteria symptoms is predominantly headache, body pain, myalgia, and diarrhea, sore throat. These are all the 4 minor criteria symptoms. So we categorize the COVID symptoms or viral infection as mild, moderate, and severe based on the category. Category A symptoms is the patients with mild illness usually have fever with either one major criteria like body pain or dry cough and loss of smell and breathlessness. Cough, breathlessness, and loss of smell, any one of these major criteria, plus body pain, sore throat, and running nose, sneezing, and diarrhea. These are all the minor criteria. So when we categorize the symptoms, mild symptoms predominantly with only respiratory problems, they can have an household contacts, household stay at home, take some paracetamol, and be there in the well-ventilated rooms. Wait for about 3 days. Most of the common flu symptoms will automatically settle down on its own. In case, if they progress on to develop some sort of a breathing difficulty, and then definitely they should approach and come to the doctor. And the healthcare workers provider on arrival of the patient, they check the temperature, check the heart rate, the respiratory rate more than 24, if the saturation is less than 94% on room air, get a chest X-ray. If it is normal, then we can manage at home isolation. In case if the chest X-ray shows some infiltrations and patients slowly going for a tachypnea, tachycardia, hypoxia, then definitely the patient needs to be admitted in a COVID isolation ward and be managed as per the protocol. So based on the presentation, we always classify as a mild, moderate, and severe symptoms. The symptoms.
So you're trying to say mild symptoms, the patient can stay at home. When the symptom exceeds more than 2-3 days, they can approach the hospital, and then
Yes,
hospitals can take a call whether they should come to the hospital, or in case
in the background, yes.
Yeah.
In the background of comorbidities, the patient more than 60 years of age with a background of chronic diabetes, systemic hypertension, COPD, chronic liver disease, chronic renal failure on dialysis, immunosuppressions, cancer chemotherapy patients or cancer patients, HIV patients, all immunocompromised patients, definitely with the background of the symptoms progressing from mild to another moderate grade. Fever more than 5 days, tachypnea, tachycardia, hypoxia, with chest X-ray findings. Definitely, it needs to be admitted for further management.
Jimmy, can I just summarize? I think it's important for the public. I think it's very difficult for them to classify themselves into whether they are mild or moderate. I think they need to know when they would come. Maybe they should ring a hospital to find out about whether they are eligible for admission or not. But in simple terms, if I simplify this and say to you that if somebody's got cough and fever and they are starting to get breathless, they have to approach hospital, don't they?
Yes, definitely.
Breathlessness is probably one of the signs that they can't sit at home and wait. Isn't that a message that you want to very clearly tell people?
Absolutely, sir.
They're getting hypoxic when they are getting breathless.
Yes.
Okay.
And any change in the neurological condition? Some of the younger age group have been told that they can cope up the breathlessness for the longer period of time, but they can become a little bit drowsier actually because of this hypoxemia, and then they started to retain carbon dioxide, so they become a little bit drowsier. So any history of shortness of breath or any changes in the mentation, I think they should approach the hospital as soon as possible.
Yes, sir.
Yeah, is it okay? So we have what are the non-chest related problems actually? For example, could the patient come to the hospital only with a GA symptom or neurological symptom? How often these symptoms occur, and then when should this kind of patient should approach without any cough, cold, fever, anything?
The atypical presentation is very common because once this pandemic is established, we are classically looking in terms of respiratory persons. Now, once we move, the pandemic stabilizes, I'm sure definitely we are going to see some sort of rare manifestations and presentations like neurological presentations, GI manifestations, but the contagiousness and the infectivity of the patient presenting with the GI symptoms will be definitely on the lower side comparatively to the respiratory droplet infection, which carries a very high infectivity.
Okay, Dr. Lalita, I have a question. What's happening in the US right now? Where do you work? Which area you work? And when do the patients approach the hospital? When do you admit them? So what's happening now? Can you explain what has been happening the last 1.5 months? What was the scenario a month ago? And then the scenario has changed now. What's your view on it?
Sure, thank you. I work in Boston. Topographically, I work in the Harvard University hospitals. Topographically, we're very closely situated to New York, and we have a constant flux of traffic from New York to Boston. So New York actually saw a very exponential rise in the number of cases over the last 1 month. I think about 1 month ago, the number of cases in New York was like less than 100. And right now it's like 140,000 in New York.
So can I stop you there? 1 month ago, at that point of time, were you predicting more number of patients coming into the hospital? Were you have you started preparing yourself to receive more number of patients at that point of time? So what is happening there? And what would be your advice to our country now? I'm sure you would have learned something from the mistakes what you have done as a country in US. And what will be your advice to us?
So I probably shouldn't boast, but I think Massachusetts was in a better position than New York. Probably because we're better in the medical system. No, I'm just kidding. To be honest, we could have taken a lot of lessons from China, which we did not. It's probably a little bit of the US mentality that we're probably not as immune and not as susceptible to everything like the other countries, which is not true. We could have prepared ourselves better in terms of personal protective equipment. We could have garnered more ventilators, made more ICU beds available, and at least switched a lot of the rooms to become negative pressure rooms. Be they be in the OR or in the ICU, or even some of the makeshift trailers which have been made into negative pressure rooms. We could have done all these. And it does take a little bit of mechanical gimckery to actually do this. It takes a little bit of time. So not all of the ORs are negative pressure rooms. Not all of our step-down units are negative pressure rooms. They have to be made so. And in fact, if you do that, you're adequately prepared to treat patients in isolation and prevent further spread of the infection. So we probably did not end up doing this a lot in New York at the beginning. And New York being New York, there's very little options for adequate social distancing. It's a very congested place. People walk shoulder to shoulder. Everybody uses the subway. So it's the risk of transmission of the infection is very high. We could have adopted social distancing and isolation rules much earlier, like what India has done. Actually, it's pretty good that, this putting people in lockdown, at least like minimizing social contact, closing groups, meetings, canceling like public gatherings. All these are like probably good ideas which should have been adopted much earlier. So even now, I think all states in the US don't have a stay-at-home order. I think 8 states definitely don't have a stay-at-home order, whereas many of the other states do. So what I would suggest is definitely equip your hospitals better, in the sense, make more of them negative pressure rooms, make sure that you have better ventilatory and ICU capabilities, not only like just, ventilatory capabilities in the ICU, like even personal protective equipment, and basically like more suction catheters, more respiratory isolation, better humidifiers, better HME filters, all these in the ICU. Everything is important so that you can actually dispose of them safely, also have better disposal methods. If you're going to use incineration, improve your incineration facilities. All these have to be made available. And social distancing is really, really important. If you gather in the tea shop to discuss about what's the situation currently happening, that's not going to be adequate social distancing. That's a sort of a force of habit for us in many places, and that should be avoided. But other than that, I think India is going in the right direction. We are making sure that PPE is available, everything. So we learn these mistakes late, and we're trying to correct ourselves in the pathway. And many of the states have actually learned from New York and have made better facilities available. So for in our hospital, one of the major things I would advise is having a triage officer, right? So somebody who actually talks, who has a team, a triage team, which is composed of an emergency physician or a casualty medical officer, and then who also has an emergency nurse, and then somebody else who's also has a team of medical assistants who can like measure the blood, temperature, measure the vital signs, make sure that the patients are adequately isolated, and then also have a social worker who also, or an equivalent in India, will help to tell them about what can be done, who they can contact in case of an emergency, how they can isolate themselves, how they can get government help, all those kind of things for people of lower strata. So unless you adequately treat every strata of society, you're going to see an exponential spread. And that's what happened in New York. I think the blue collar jobs who went to work by the subway, who lived in like congested areas, those people, they weren't, who didn't have healthcare insurance, who could not contact the doctors in time. That's where we saw the spread of the infection.
Thank you, Dr. Rela. Even our government has been putting a lot of effort. I think lockdown was kickstarted well in advance. I think that's a major advantage actually. And then the other advantage is getting the disease a bit later instead of as an early. I think we are learning a lot of things because the disease will come a bit later in our country. Even in our state, Tamil Nadu government has been sending people to individual houses to check. Almost once in a week or once in 2 weeks, they are sending people to check whether any of the household members are infected, and they're not revealing the information. So those kind of activities are followed up nicely here. And when do they approach? What's the government protocol for the public? When will they approach the hospital in the US? Is there any guideline given by the government?
Yeah, we have a system wherein you can call in actually. So the partners, the Harvard hospitals, have a helpline, a public helpline. You can just call the helpline and you can tell what your symptoms are. And there'll be a group of triage nurses. The triage nurses actually sort out your symptoms and tell you what is your, probably using the same major and minor criteria, but they tell you what is your likelihood of your having the disease and what is the risk that you stay at home versus you come to the hospital. So that way we try to minimize the number of people coming to the hospital. And we also give them like help, like, please maintain social distancing, remind them of all the rules, and remind them of what helplines they could call in case of a problem. And of course, our government has issued a big financial incentive for people to which they can avail of if they're running small businesses, if they're having daily jobs, if they're having like blue collar jobs, whom they can call so that they can still adopt these social isolation rules and, not go to work and still not be like, sent adrift. So I think these measures can be similarly adopted by the Indian government. They can have a helpline, which I think they do. And, similarly, if we could have like a regional distribution of the helpline information, which would help triage, I think that would be really useful in sorting patients which have to come to the hospital versus those who can stay at home.
Yeah, even many of the states.
Can I interrupt, Ilan? I'm sorry.
No problem.
Yeah, sure.
Lalita, we were talking
fine.
about lessons that we have not learned from China. Now, I'm not sure if we have actually entirely learned all the lessons. One of the worries that I have is the risk for the medical professionals. Now, when you look at Italy, I believe there are 71 doctors have died out of this corona episode there. I think 71 doctors dying in a small country is actually a disaster. And in actually one of the hospitals in Mumbai has been shut down because almost 40 health professionals were found to be infected. I mean, are we not used to the discipline? The Chinese apparently have had no deaths in the medical. I mean, they have had very few deaths amongst the doctors looking after these patients. Is it because there is lack of availability, or there is lack of discipline in how we use these equipments, or are we less careful than the Chinese have been? Is there a lesson for medical professionals? Because if medical professionals are sent home, who's going to be left to look after patients when things get really worse is one of my worries.
Yeah, that's a very good question. I'll be honest. So actually in our sister hospital, Massachusetts General Hospital, about 100 healthcare workers were actually either tested positive or quarantined during the initial stages. This was before we realized that healthcare workers not only are endangered, but they can probably endanger patients they come into communication or contact with. So it's really important that we protect our own healthcare workers. And we kind of realize it's late because we don't have enough PPE in stock. Till like maybe about 2-3 days ago, when we received a huge bolus of N95 masks, peppers, and other personal protective equipment. So I think making the personal protective equipment available is a major limiting factor. Unless we stock up and stockpile on these, like in anticipation of what's going to happen, you're going to be find yourself like shorthanded. In that case, automatically, all of us, none of us are going to stop treating patients or, help treat a patient who's really, really sick just because we have inadequate equipment. You're going to like probably make do and go ahead when you see a patient who's about to die or is really sick. And that's the problem, right? So we have to make sure that we do have adequate facilities available. So I think adequate PPE availability and shortage was one of the risk factors in Italy. I think China has a major ability to produce adequate equipment at even short notice. And I think initially they did have a few deaths in the healthcare field, as well as multiple exposures, and a lot of people did actually fall sick, but they quickly caught up and they managed to institute very strict rules about people reporting to work and so on. And that's why they managed to actually curb that tendency. So now we actually have a sort of a online pass, which we have to avail of every day, like wherein we have to log in all our symptoms or the lack of symptoms, and then we get a daily pass. And then only we can actually go into work. So that could be easily done in India also. We could have a quick app and we could actually list what our symptoms are. And then, you isolate all those people who have any sort of symptoms and say, hey, you guys stay at home for 1 to 2 days. You're not cleared for work. And those who are cleared for work alone actually report to work. That's one way that we can actually decrease the number of people who are probably exposed to the virus. And the second way is to increase your PPE. And the third way is to actually make sure that these PPE is available to all patients, all staff at all ends of the spectrum. For example, I'm part of the airway team who go around the hospital intubating all the patients with COVID. So I have adequate PPE in my cart, but when I move to another lesser populated area, like for example, like one day we went to the CT scanner to intubate a patient, right, who was acutely short of breath. So in the CT scanner area, there's not much of PPE. So if anybody else wants to help me during the process of intubation, I have to exhaust my own reserves of PPE. So just make sure that they're uniformly distributed. You know, you have adequate PPE available on all sites so that in case of an emergency, you can have it available. And the second thing is we have an employee hotline. So in case you have any problems, you can call the partner's employee hotline and say, these are your symptoms. And we have special COVID testing for in-house employees, right? So if you have testing preferentially made available to you, there's a less risk that you're going to probably transmit the infection when you're asymptomatic or when you're mildly symptomatic. Because at least if the testing is freely available, I think that was one of the major limiting factors in the US. Testing was not universally available. And because we were short in testing kits, you know, so that actually caused an exponential rise in the number of cases before they were detected. Obviously. So I think that could be one thing which could be really thought about in India. If we made more testing kits available, you can detect more patients, you can isolate more patients, and you can really flatten the curve. We did that major mistake in certain states like Washington and New York states. We did that mistake. So now we have more testing kits available, especially for in-house employees. We have also some drive-through centers wherein certain areas of the hospital, for example, Newton Wellesley Hospital, just outside Boston, you know, you just have a tent where there's certain employees who are wearing hazmat gear, and they actually, you can have a drive-through testing where they take a nasopharyngeal swab and they give you the test. You don't need to get out of the car, and the employee contact is also minimal. So both patients and employees can actually go through this drive-through testing. And the whole apparatus is encased in a tent, which actually isolates further exposure to the environment. So you can probably do a similar thing in India. India has a really good baseline public health system. You know, for example, you just consider the pulse polio program, right? A whole bunch of people just converge to make sure that all kids are immunized, inoculated. So if we could use that healthcare system and basically make sure that we have good drive-through testing, good isolation of healthcare workers, availability of PPE, availability of testing, you won't see such a horrible acceleration of the curve.
Thank you, Dr. Lalita, for your
Sure.
experience and what's happening in the US. I will come back to you a bit later. Being a developing country in India, we have been trying to do something with the resources available here, actually. So I just want to ask Dr. Akila regarding what could be done in a healthcare setting to prevent a number of healthcare workers to get infected. What's your advice, Dr. Akila?
Now, looking after the healthcare staff is the most important priority at the moment, I should say. The most valuable resource of the country at the moment, of any nation for that matter. We did hear a lot about the mortality which the healthcare workers suffered in China and Italy, and lots of them in US still not reported fully. So to protect our staff, as Lalita also pointed out, the PPE availability is the most important thing. It's not just the availability, the training in use of PPE, the appropriate PPE, and using them more appropriately. Say, for example, using an N95, everybody is paranoid about using an N95 mask. It's not just about using them appropriately is very important, having an appropriate fit. So all the staff require regular training, irrespective of the presence or absence of a patient. So basic training is also important. About knowing about the overview of the disease, the mode of spread, hand hygiene, cough etiquette, and all those stuff. But also you have to concentrate on the frontline workers who are going to deal with the COVID patients. So PPE donning and doffing. You should have several mock sessions and simulator sessions that will help them to don them appropriately. And it's also shown that having observers while they're donning, having a buddy check just before doing that, and also during doffing. During doffing, it's shown that the risk of contracting infection is high. So you should have a buddy check while they are doffing. Now,
okay. Based on your experience in the last one month, what would you advise to other centers? What would be the top 3 priorities would you advise? in case of some of the centers or some of the centers in the peripheries wanted to start something new in their hospital to protect the healthcare workers, what are the top 3 priorities would you advise them?
Yes, we spoke about this. India is quite fortunate because we had enough time to prepare. The first thing I should say is you have to form a COVID task force, because each hospital will cater to a different set of population, and they will have different specialties, clinical specialties coming to them. So you should have a COVID task force which identifies lots of other things. There should be lots of subcommittees which will decide how to have a set up an isolation unit if there is a facility within the hospital, or you have a separate block which can be designated as an isolation unit. That is one thing, one important thing. Then there has to be workforce planning. You have to reorganize your clinical services, say only emergency procedures can be done. Rest of the things can be handled as telemedicine consults. Non-essential clinical staff can be made to work from home. Identify the core clinical team. You should have robust SOPs, protocols, and procedures for each and every minute thing which we think is less important, but they should have checklists just before intubation, like anesthetists are doing it for several years. But still, it is important to have a checklist to make sure all your equipment are in place, a body check to make sure your PPEs are properly donned before you go for the thing. So there has to be a core clinical team who's looking into all this SOPs, protocols, and procedures, and they should also be regularly taking updates.
Akila, can I
Yes.
ask a controversial
Yeah.
question? Now, we worry that medical staff can get infected and they'll go off work. Now, we know that there are many asymptomatic people who can transmit the virus. Do you think there should be a recommendation that all medical staff should have their tests done, whether the rapid test that's available now or the PCR test, to show that they are COVID negative, so that they can look after, I don't know whether the COVID patients, when they are looking after non-COVID patients, or when they've been exposed to COVID patients and are also looking after non-COVID patients, that these doctors should have regular tests done in order to protect the non-COVID patients. We know that we have for many years doctors who are hepatitis B positive have not been allowed to do invasive procedures. They have to show that they are immune to hepatitis B, vaccinated, before they can actually look after patients. Do you think any such regulations is likely to come? Because it's not there anywhere in the world. I don't think they're testing doctors before they're looking after patients.
The feasibility of testing is going to be very difficult, Prof. It's not easily available, and there's a very high problems of false negatives with all these testing results. So if you do a nasal swab, they say only about 40% sensitivity is there. So we might not be able to still pick up a lot of asymptomatic carriers. It's better to go with the symptomatic ones and have your PPE, strict hand hygiene, cough etiquette, and all those contact precautions will go a long way, is what I feel. It might be difficult to screen all the healthcare workers if they're asymptomatic.
Okay. Thank you.
What do you
Only thing is, if somebody is treating these or seeing these COVID patients, and if they come into close contact, there is a guidelines for close contact. Those people should not go and meet high-risk people like immunocompromised, transplant, chemotherapy patients. They should not be allowed for 14 days. That's the best way to prevent healthcare concern giving to the others. Otherwise, this is the recommendation.
Thank you, Dr. Abhi. I think Dr. Akila has spoken about what a bigger center or a small nursing home should do. What would be your advice for a clinic? In India, I'm sure if you look at the number of private clinics where there is a single doctor will be seeing 50 to 100 patients per day, what are the precautions they should take? How can they screen the patient in case if the lockdown is closed in 2 to 3 weeks time or next week? What will be your advice? How should they prepare themselves to avoid spreading infection in the particular clinic?
Definitely, they should plan to have a triage system. They should have an appointment system to work on these patients so that they are priorly aware, triage all the patients who are coming. And if possible, do a teleconferencing or video conferencing and try to sort out those patients. And in your hospital or places, you should have social distancing between the patients. have signage for the respiratory tick, have hand rubs and hand hygiene information circulated there. And even when you see patients, the doctor and patient should have 6 feet difference at least, 2 meters, except during the examination time. And the doctor should frequently wash hands. And once the patient moves out of the place, they have to clean that area very well. And doctor should check is fever and flu. These are some other things. And doctor should wear a mask and a glove always.
Thank you, Dr. Ravi. I have a difficult question for Dr. Vidya. Do you think the lockdown period should be extended? What's your view on it?
Sir, actually, the lockdown period is based on various mathematical models and public health expert based on the incubation period of this particular virus. The median period of the viral shedding is supposed to be 17 days, although there have been patients who've shed the virus up to 37 days. So based on this, the lockdown period has been decided as 21 days, 14 days plus another week. But whether it has to be extended, I'm not sure. If it is extending, it will only give the hospital systems time to prepare more. It will also help in flattening of the curve. But at the same time, today I happened to read an article from a very good epidemiologist who says you should actually separate the elderly, but let the younger population mix up so that we do develop herd immunity. So at least 60% of the population get infected with the disease. But I think we should get more on this from the public health experts and the epidemiologists.
So yes or no?
I wouldn't want to comment on this. Although I think social distancing definitely would reduce the R0 and will actually help us prepare more.
So we have a slide projected there. Do you want to talk through this slide?
But Vidya, can I interfere with what you said, that we should allow the younger people to get infected and improve the herd immunity? Isn't that what the British Prime Minister said in the first place as the policy for the UK, was just going in the opposite direction?
Which exactly, sir. Exactly.
And he is himself in the hospital now, and they are
absolutely. Yes, but
so they could have made a decision to go for a lockdown earlier on rather than switch in the middle, and it's turning out to be a disaster.
Correct. So,
but don't you think? See, now we have got crops of patients in different parts of the country. In Tamil Nadu, they are saying that they have got some 90,000 people. I don't know, in Chennai district itself, I think there are 90,000 people in a lockdown. So those extending the lockdown should help, shouldn't it?
So yes,
there's
sir.
no question it will help.
Definitely, that's what I mean. There are a couple of papers from the Cambridge who says that there should be an extension of the lockdown. But depending, this is again on the way our families are. We have 3-generation families. So there is a lot of questioning on this as well, because we have 3-generation families. Will the extension of the lockdowns actually help? So this is all conflicting. So I am not really sure if it helps, but there are reports saying that they should extend the lockdown to 49 days. That's some Cambridge report that I came across.
Yeah, I think I'm a great believer of lockdown actually, because even if you relax it a little bit, I think it will still be reasonable, but you should be able to contain the disease much better with the lockdown. And it dies down, doesn't it? Your R0 comes down significantly, because one individual person infects, say 3-4 people around them, but the 4 people around him who got infected are not going to infect further. So the R0 will drastically come down. You said it comes down below. Those 5 people who got infected are not going to infect anyone. It drops to below 1, doesn't it? So
yes, sir.
So that would be a very effective way of controlling the disease.
And thank you, Prof. We have been saying that we have to protect the elderly, we have to isolate them, the kids needs to be separated from the adult groups. But if you look at our country's status, looking at the housing, how many houses will have 3-bedroom, 4-bedrooms, where you can have 1 bedroom for kids and another bedroom for adults? I'm sure it's going to be really tough to say that we have to completely separate adults from kids. I don't think it's practically possible in our country. If you look at the number of people living below poverty line, it's more than 30%. I'm sure only 10 or 15% at the top cream group will have a 3-bedroom or 4-bedroom house where they can actually isolate elderly population or the high-risk population. So it's going to be a really difficult situation if we are going to say that we have to isolate them separately. I don't think it's practically possible in our country. Prof, what do you say, Prof? Do you agree with me?
In a lockdown where family members are together, I don't think it matters. I think Vidya meant that when you actually release the lockdown, you allow the younger people to go back to work and mingle. In that situation only, she said that you need to isolate the elderly people from the younger people who are returning back home. Isn't that right? Isn't that what you said, Vidya?
Yes.
That's my point also. Even that period, when you're thinking about after the lockdown period, where the risk is still higher, you want the younger group to get exposed, and then you want the elderly group to get isolated. But if you look at the housing facility in our country, that option is not available.
Yeah, I mean, if that is the case, those families may not be able to do that, actually.
Yeah, that's a big problem.
You can still relax. I mean, we have a big problem in Bombay. I don't know how that is going to pan out. You've got the biggest slum in the world with patients being recorded. I don't know how efficiently they'll be able to contain there in that location. So we need to wait and see, actually, if that is going to explode in a big way, or Bombay, Maharashtra is going to control that efficiently. I hope that they will be able to.
Dr. Lalita, you want to say something?
I'd just like to add that recently in New York and Boston, we've had a lot of case fatalities among younger individuals. We can't really explain why this is happening. We've had like a bunch of, I think there was even an ENT dental surgery resident who died, who was otherwise really healthy. And there was like a bunch of other people among healthcare workers, nurses, everybody who died, who were otherwise did not have much of comorbid conditions. So we have to keep that in mind when you consider commingling as an option, because it's not that younger patients are completely, devoid of any possibility of mortality. That's also a possibility. And we've started seeing this more in New York and Boston.
Okay, thank you. So I have two of my colleagues sitting next to me, actually, Dr. Anjana and Dr. Premchandar. They have been saying me that there are questions being flooded in their mobile phone and in some part of the Facebook, actually. So there is one question which says that hydroxychloroquine usage among healthcare professionals. Recently, a couple of weeks ago, ICMR has given a guideline to say that a high-risk group can take hydroxychloroquine as a prophylaxis. Dr. Vidya, what's the current status? I know that even a lot of public has acquired a lot of tablets from the pharmacy and kept it in their house. What should we do? Do you think all the healthcare workers should take this hydroxychloroquine as a prophylaxis, or do you advise all these high-risk groups like elderly age group, hypertensive, diabetic, those people should also take this tablet? What's your advice, and what is the ICMR guidelines say?
Currently, for public, there is no recommendation. And if you really look at literature, there is one study from the Minnesota, and there is another trial which is supposed to be recruiting, and one study which is on hydroxychloroquine in the setting of post-exposure prophylaxis, which is which will start shortly. But the ICMR guideline recommends prophylaxis in the setting of healthcare only for patients, for healthcare workers who are exposed to or suspects or proven COVIDs. So that is the guideline for them, and also to family members of proven COVIDs. So that is the only two set of groups that you can give hydroxychloroquine prophylaxis to. I think the duration of prophylaxis would be around 7 weeks in case of the healthcare workers, and it's a shorter duration in terms of the family contacts of proven COVIDs. So outside this setting, I don't think we should recommend. I'm not really sure about the basis of the prophylaxis that the ICMR has recommended. I'm sure they will have their own evidence, or we may get recommendations why they recommended this prophylaxis. But from the scientific literature, we just have 2 ongoing trials. So outside these 2, we in India would not recommend the public to take hydroxychloroquine at all.
Thank you, Dr. Vidya. We have one more question to Dr. Jimmy Prabhakar. Now people are going outside to buy stuffs and using their vehicles and coming back using the lift. So, for example, if somebody goes out, buy some bananas, buy some soaps, when they bring it back, what are the chances of spreading the infection? We know that the virus stays on the surface for quite longer period of time. For example, if they go outside to buy some stuff, what's the possibility of carrying that stuff in that uh, whatever we buy it, to the house? What should we do as a common public? Should we wash or what should we do?
The viruses stay in the environment and the plastics. It can stay in the cardboards, papers, everything. But as far as the vegetables items and packed items is concerned, FDA has given a current guidelines that there is no evidence of any transmission, risk of transmission in handling the food and the packed food items. So, but to be on the safer side, when we buy vegetables, when we buy all the food items, when we go into the lift, always preferably don't touch the lift, go in the staircase, don't touch the railings. And once you enter the home, the guideline says preferably hand wash and then take the all the vegetables, wash it, and then use for the regular cooking purposes. So the safety measure is just clean, cook, and chill. That's it. But as far as the guideline is concerned, FDA has categorically says that there is no evidence which states the risk of transmission as far as the food and the packaged items is concerned.
Yeah, thank you, Dr. Jimmy. I have a question to Dr. Naresh. We have been talking about kids, children. We know that the mortality in younger age group is almost nil, or I would say it's very minimal. Why do you think the children are protective from this virus, Dr. Naresh?
You know, children are always special, and you know, seeds are always stronger than the fruit. I think that's what nature has tended us. And essentially, children might not produce the cytokine strong. I think still it's only theoretical. One is like they don't mount the response, the cytokine storm response, so that they don't get unwell. And the other thing is they sort of they have been exposed to a lot of viruses in the form of vaccination, BCG, and that could be a cause. But all of them are assumptions. Nobody knows why children are quite resilient, might be their immune system. But what's the problem with children is they can be the carriers. Since most of them are asymptomatic, they can be the carriers spreading the disease. So as I think we had some discussion about older people and children. I think when there is small kids, the older people tend to sort of kiss them, hug them. So I think at least we can avoid those things so that they get distance from the little kids.
Thank you, Naresh. And then children normally used to get flu-like symptoms very frequently. Yeah. When should the parents bring the child to the hospital? How can a parent differentiate a flu-like symptom, normal flu, and then coronavirus-induced flu? Is there any way they can clinically analyze and think and take a decision?
I think Dr. Jimmy Prabhakar has already discussed about this with regards to the adults. In children, the principle applies the same. For mild cough, cold, fever, they can give some antipyretics, wait for 2-3 days time. And if the child becomes breathless, one of the main symptoms in children can be lethargy, where they can come to hospital thinking whether it's meningitis. So if the fever persists for more than 3 days, severe cough, productive cough, the child is drowsy, they have to come to the hospital. Otherwise, they can speak to the pediatricians over phone, get some advice, and keep the children at home. It's quite difficult to differentiate categorically that it is flu or it is COVID.
And how should the hospital handle the children when the children started coming to the hospital?
I think
difference between adults?
I think there is no difference. I think when a child comes to hospital with cough, cold, or asthma, who's a wheezer, who needs nebulization, I think they have to be treated exactly like how we treat the adults. I think the doctors should be wearing the PPE, and these children has to be segregated, kept in a separate place until we prove that they are COVID negative.
Yeah, there is a question for Dr. Aishwarya, our pulmonologist. In the last 3 months, is there any improvement in terms of finding out newer drugs, any changes in treatment option available? For example, hydroxychloroquine, people have been talking about that, antiviral therapy or ventilator management. What has been happening around the world, and what should we do here?
Yes, sir. So as of now, there are so many antiviral trials that's available. The drug that is FDA approved as an emergency approval right now is hydroxychloroquine, and with an adjuvant of azithromycin. And antiviral approval have been given for lopinavir, ritonavir, even redemsivir is a drug that's been used. And frapinavir is a drug that is on trial. And apart from it, the other adjuvant therapies are tocilizumab, which is an interleukin-6 receptor inhibiting monoclonal antibody, wherein this drug has been proven effective in a lot of patients who has had a cytokine storm. Another drug is another monoclonal antibody is lenvatinib, which is also used during the cytokine storm. So these are the drugs on trials that has been available right now. And a few weeks back, there was a paper that was published wherein the covalescent plasma, there is a plasma from the individuals who had recovered from COVID, that is 2 samples would have been negative for those patients, and from the exposure to 28 days, their plasma can be collected, and that can be used for the treatment of, that's also under trial right now. So their plasmas can be used for these patients. And recently a paper on ivermectin that can also be tried on patients with SARS-CoV-2. So these are the drugs on trials that's been available right now, sir.
Yeah, thank you, Dr. Aishwarya.
Can I ask something to Aishwarya?
Yeah,
yes,
sure.
sir.
Now, I mean, the trials with hydroxychloroquine or chloroquine have come about because somebody has suggested that it's got some action. You know, in general terms, everybody, I don't know whether it's political or not, they always say that there is actually no strong evidence.
Yes.
And that's why they are not recommending to the general public as prophylaxis. I mean, we don't even know whether there is evidence for prophylaxis for this drug.
Okay.
Now, where was that little evidence? I know there was a paper, French paper that everybody criticizes about.
Yes.
So somebody must be believing in it. The Americans must be believing in it, and Europeans must be believing in it to start a trial. And if there is the slightest of the hope, let me put it this way. If there is the slightest of the hope that this is going to work, and if the trial results are going to come in 2 to 3 months, is it unreasonable for the general public to think that I want to try it? Whether it works or not, I don't care, but I want to try it. What do you say to them?
Okay, there is a paper that is being published by Lancet, so answering a little bit to this is the paper was published in March 11th, I believe, that says a link between the ACE2 and the SARS-CoV. I'll explain what it is. So every individual has ACE2 in their type 2 pneumocytes of the alveoli. So apparently this ACE2 has a tendency, or the glycoprotein S, as there was a picture that was put in the beginning, the race of the coronavirus, on top of it there's a glycoprotein S. That glycoprotein S has an affinity to get attached to these ACE2 that is present in most of our lung tissue as well as the gastrointestinal tissue. So the chloroquine and hydroxychloroquine, being immunomodulators, has a tendency of this ACE2 receptor inhibition. That is the bonding of the protein S to the ACE2 has been inhibited when the patient takes hydroxychloroquine and chloroquine. And these are studies which was done only on mice. And this was something that was proven for SARS-CoV in 2000. And there was a paper that was a proven paper. So I think that's how this chloroquine and hydroxychloroquine came into picture. So when a patient is on chloroquine,
the in vitro studies also said that it is it works against COVID-2, doesn't it?
Yes, so because of this, mainly because of this ACE2 cellular receptor inhibition, and these two are immunomodulators and they worked well on cytokine storm, which is a biggest thing that is happening in these patients, that is from the cytokine storm, they immediately go in on ventilators and the mortality rate is high. So I think that's why these hydroxychloroquine and chloroquine came into picture.
Prof, might be
So, I mean, yeah, go on. Sorry. Yeah.
Prof, might be the availability of the drug is one of the reasons why the recommendation hasn't come for general public. Because chloroquine is in shortage. Even for healthcare professional, it is in shortage.
I think people have already bought it and kept it at home.
And as Dr. Vidya said, it is right now the guideline says only for people who are healthcare workers being exposed to the COVID positive patients as well as suspects, as well people at home who have been come in contact with COVID patients should only take hydroxychloroquine and not all of them. So there's no need to stock, public no need to stock the drug right now.
Good, that's a very clear message, Dr. Aishwarya. There are a couple of questions to Dr. Dinesh. We have questions from Sri Lanka and also from Bangalore. People wanted to know, especially from transplant recipients, should they get worried because they are taking a lot of immunosuppressants, not only liver transplant recipients, even rheumatoid arthritis patients, they take immunosuppressants, liver, kidney, all the transplant recipients will be on some kind of immunosuppressants or steroids. Are they at risk of developing COVID? What are the precautions they should take, Dr. Dinesh?
I think, yeah, I mean, first of all, we've been receiving a lot of calls on this over the last 3-4 weeks. What should I do, doctor? You know, should I take hydroxychloroquine? One patient even sent me a photo saying, I've been started on hydroxychloroquine by my relative, all those things. So, you know, it's very important to understand the importance of the immunosuppression, all this in this context. See, first of all, post-transplant patients, they are on lifelong immunosuppression, and patients with the chronic disease like rheumatoid arthritis, they'll be on autoimmune hepatitis, they'll be on lifelong immunosuppression. Yes, patients on immunosuppression may more likely to acquire the disease. But with the little evidence on these, very little evidence in these patients shows that they may not develop the cytokine storm. Most of them develop mild disease. So that means that they may shed the virus for a longer time, but they themselves may not get the severe disease. So there is a hypothesis that immunosuppression can be little protective from developing a cytokine storm in these patients. But again, the evidence is very little for that. We have to wait and see over a period of time to see how these patients react. But at this point of time, we could say that transplant patients are not at very high risk of developing severe disease or so forth. And also not only so, and also equal number of patients are asking us whether they should cut down immunosuppression. Once again, right now, there is no evidence to cut down the immunosuppression without consulting your transplant team, because cutting down immunosuppression means if your organ gets rejected, you'll be given steroids and unwanted issues, and then you are more prone for opportunistic infections, etc., etc. So what I would suggest for patients who, the transplant patients or immunosuppressed patients, is going back to the fundamentals of patients, what the government advises, what's the local policies. We have to have a strict hand washing policies. You have to wear masks, avoid, socializing, and maintain social distance. And if you have any symptoms, get in touch with your transplant team. And in fact, we are conducting telemedicine consultation, particularly to reduce the apprehensions and anxiety amongst the transplant recipients, because that's very important to reassure them that taking immunosuppression is not going to contribute to the disease directly. So therefore, they should not stop. And also they should avoid taking unnecessary medications. For example, this hydroxychloroquine has been the most common question that we come across amongst the transplant recipients. So they should not take without any consultation on their own, because some of the drugs are metabolized in the liver. For example, lopinavir, all those drugs, or cytochrome P450 inhibitor, they can increase your tacrolimus levels and lead to severe toxicity. And these are very, very important. And if they have any symptoms, they have to get in touch with the transplant team as well as the local doctor for the definite advice. Actually, that is very important.
Yeah, thank you very much, Dinesh. There is a question for Dr. Vidya and Dr. Ravi also. I think somebody from Hyderabad, they asked the question. The question is, my relative, my husband is working in a healthcare setting as an patient care service person. When he comes home, what kind of precautions he should take? Because there's a high risk of that person carrying that infection home. Not only anybody like a doctor or nurse or anybody, whether the person is looking after the patient or they are working in a non-clinical area, there is a possibility that they might pick up the disease along with them and then spread that infection to their family. What kind of precautions, what should they do when they come back from home? Dr. Vidya, Dr. Abi, one of you can answer.
Okay. Being a healthcare worker, you need to make sure you remove a shoe at the door, clean all the belongings, ID cards, take less things to the hospital and bring back home. That's very important things. You don't need to carry bag in and out. And if possible, remove the clothes, put it to wash, soak it and put it to wash, take a bath as soon as you go home, and get good rest and get hydrated, because your health is dependent upon your stress level also. And restrict your movement, because as you said, in a country like India where you have a lot of vulnerable population, if you have vulnerable population, try to avoid interacting with them much. No hug, no kisses, and if you could use a separate toilet, well, it's very important. And hand wash, that's a very important thing. You need to do hand wash very frequently when you come back home, and after you take bath, all the knobs has to be cleared. Avoid sharing any of the utensils which you are using. And as I said, if monitor your temperature and for symptoms, if you have any of them, call for help immediately.
Yeah, thank you, Dr. Ravi. There is a question about.
Glenn, can I just continue that? You're a hospital administrator as well. Isn't there some suggestion that when doctors are on call looking after COVID patients, perhaps they should do continuously on call, and they should have local accommodation provided for a whole week and then go home for a whole week? So the in and out every day, coming home and going back, is significantly reduced. Most of the nurses are obviously staying in accommodations within the hospital, but those of them who are going home also, shouldn't there be some provision to accommodate them so they can continuously do some work and then go home and take rest for longer periods of time? Isn't that a suggestion?
Yes, that's true, Prof. Ashley. I can share what we have been doing, and Dr. Akila can add on top of this. So what we have been doing is, we have kickstarted the program a month ago. We have started developing a COVID isolation unit where we have converted some areas into negative pressure isolation. We have also created some quarantine ward, and also we have created some isolation ward to keep a suspected patient. Fortunately, so far, more than 10 patients we have sent COVID testing. Fortunately, all of them are negative. But those people, staffs who were looking after those patients, we have provided accommodation within the hospital campus itself. So they have been staying within the hospital campus. Once the test report becomes negative, once we know that the patient doesn't have the infection, they are allowed to go home. Ideally, we should ask them to stay in the campus or somewhere nearby for at least for 2 weeks. Unless otherwise they have a separate house where they'll not have any contact with their family members, they can go back in some of the routine areas. Otherwise, it's better for them to stay in an isolated area. That's what we have been doing. Dr. Akira, do you want to add anything on top of it?
Yeah, I think that's pretty much it. Actually, it's been shown that shorter duration of work helps. So we sort of propose 6-hour shifts, so they can work for a week and then take a week break. That also reduces a viral load and viral shedding if they are asymptomatic carriers also, and they can come back to work in the COVID unit, or if they have to work in non-COVID areas, you have to quarantine them for at least 14 days before they can come back. Most of the healthcare workers don't prefer to go home because they're worried they carry the infection home. So a separate accommodation has to be provided either inside the hospital or outside the hospital campus. Look after all food and other logistics arrangements, so that they do the shifts, they have a shower inside the area, and then they go back to the accommodation. That's what.
Yeah, Dr. Lalita, what's happening in the US?
No, I just wanted to add something. I'd like Dr. Ravi Kumar's opinion on that. Is that they've been recommending nowadays that since the nasopharynx serves as a reservoir for the virus, they've actually started recommending nasal irrigation and saltwater gargling as like a regular precaution for healthcare workers when they come back home to decrease the possible viral load that they might have when they're asymptomatic. And, China apparently has some success stories in flattening the curve by this method. And I was wondering what you think about that.
Dr. Ravi, question is for you.
Okay, so I have also read this material about talking about saltwater goggling, about the bedded and washed. I don't have consolidated evidence, but doing it is not harm. That's what I feel.
And some of the, some of the UK, my UK colleagues were suggesting, as well as some Chinese colleagues were suggesting like aqueous iodine, which might be used for nasal irrigation along with like just regular sterile water, might actually be helpful. There's things which can be easily mimicked at home, and it really is not super harmful. So maybe it might be an adequate solution for India also. It's pretty cheap. We can easily do it.
Okay.
Thank you, Dr. Anarita. There is a question by an audience, Mr. Arun. He says that there is a lot of talk on that corona has less effect on Indians. I would probably request Professor Rela to answer this question. There's a lot of talk on that corona has less effect on Indians and we have more immunity than others. However, data shows that 26% of patients in India died. I think it's higher than a global average. Comments, please. He says that the number of mortality rate is pretty high in India. He's talking about.
I don't think that. I don't think the mortality is higher because we have had in India now, how many patients is that? 4,900 or is that more than that?
What he is talking about is number of patients discharged, percentage of the death out of number of patients discharged, not the total number of patients.
No. You can't look at that. You can't look at that because he's looking at number of patients cured versus number of patients who have died.
Yeah.
You can't look at that at the moment because to declare that somebody is cured, you have to have 2 negative swabs. So the government had to have 2 PCR tests negative to say that they are not infective anymore. So in the course of this pandemic, it's only towards the end, in 2 months, 3 months time, that we are going to see more number of recovering patients versus the mortality. So you can't look at that. In China, if you see number of recovered to mortality, the proportion of recovered would be very high. So there are many active patients currently who will recover, who won't die. So you can't look at that statistics and say more patients have died instead of recovered, because majority of the active patients will go into the recovered group later on. So I think they are looking at the statistics slightly differently.
Yeah, thank you, Prof. And we have to slightly discuss about the testing options available. I want to ask Dr. Shubha a question. What is the PCR testing and what is this rapid testing? I think currently people are talking about the rapid testing. What do you mean by rapid testing? What is being tested? Dr. Shubha.
Yeah. Okay. I'll address the first one. First is PCR testing. What is being done is the real-time reverse transcription PCR polymerase chain reaction, and that is targeting the virus nucleic acid. And the other one, what you mentioned, is the antibody testing. So that is to detect the IgM, which is the early antibody, and the IgG, which is the late antibody meant for SARS-CoV-2. As of now, the approved method for diagnosis is real-time reverse transcription PCR. The reason is it directly targets the viral nucleic acid. So the analytical sensitivity is definitely high compared to the clinical sensitivity. There is difference. And when it comes to antibody testing, it might be a easier protocol, which is matter of 15 minutes. And you would get IgM, IgG positivity in individuals in whom they could be cross reaction, which is still not proved. So it's not come under the method of diagnosis as yet, but it has a lot of scope. Say, as of now, how ICMR has planned to keep it in only in cluster containment population, it can aid in that population in seroepidemiological and research purpose. But it's the reverse transcription PCR is the gold standard at the moment. And to tell about the analytical sensitivity over the clinical sensitivity, we always say that it's only 60 to 80% sensitive, and there are this rapid kits which is claiming 100% sensitive. So it's about the timing with respect to the rapid kits. And when it comes to analytical sensitivity with PCR, the limit of detection is 6.25 copies per microliter. So which means given 20 specimens, 19 specimens, that is 95% of samples could be picked up by the reverse transcriptase PCR. So that good is the analytical sensitivity. So what we talk the 60 to 80% is just the clinical sensitivity, which has a lot of factors such as the timing with which the sample was collected, the operator's precision, the viral load shedding, so and the severity of the disease in the patient and the site from which it is tested. So there are a lot of variabilities when it comes to clinical sensitivity. So this is the reason why PCR still standards, as the approved method for diagnosis of COVID-19.
Yeah, thank you, Dr. Shubham. I'm just showing some slides here.
Right.
How do you interpret this guidelines from ICMR? Who can get this
right.
antibody test? Can you go through this guidelines, please?
Right, sir. Yeah. What you projected is this ICMR's recent strategy for antibody-based blood testing, which is specifically only for the... Sir?
Before going there, can I just clear something? Because you were talking about clinical sensitivity and the laboratory sensitivity itself. Can I simply say for the sake of the public that if the PCR comes back as positive, it's 100% that they are COVID positive, yeah? But if the PCR comes back as negative, it's not 100% that they are COVID negative. You have to repeat it because the sensitivity is only 70%. But when it's positive, it's positive. There is no doubt about that.
Right.
Whereas you've said with the antibody test, because maybe there is cross-reactivity, we still don't know, an antibody test which is positive is not necessarily positive.
Right.
So
yes,
you have to back up with a PCR. So for the public, even though people say it's 70% sensitive, when it's sensitive, when it's positive, it's positive. But when it's negative, it's not necessarily negative. And you may, if the symptoms are really persistent, you may have to repeat the COVID test again after 2 days. Yeah, that's the message.
Yes, perfectly. Yes.
Okay, can we look at the chart and explain to us what they are saying there? So we're now talking about the quick test, 10-minute tests, yeah? And how we are going to use it and how we are going to interpret it.
Yeah. So,
okay.
As per the ICMR guidelines, who can do the test? Any hospitals can do the test?
Okay, so there are two things. With respect to the government institutions, as of now, there are 100+ institutions which are doing this test. And among the private setup, there are 65+ who's using
I'm
this
talking
test.
about rapid antibody test. I'm talking about rapid test, not the PCR.
Not PCR, okay. So rapid testing is not approved for any institution as of now. It's only under the control of government. And as you rightly projected the slide, which is meant only for cluster containment zone and large migration gatherings, wherein there is this group of individuals who are either positive or suspected contacts who, when develop symptomatic influenza-like illness, will be subjected to this rapid antibody test. And if they have come positive, so it is considered as a probable COVID and treated accordingly, depending upon the clinical severity at home isolation or in the hospital. But if it comes negative, now that I told it is a highly suspected population, if it is negative, if warranted, RT-PCR can be performed. And if it's positive, well, again, the management is the same. If it is negative, it is more likely that it is a non-COVID influenza-like illness. Similarly, if the negative, that is rapid card negative, and there is no facility to do PCR, and home quarantine would be advised in such individuals for again another 14 days. and when negative, will be told as non-COVID case. If it is positive, probable COVID, and treat accordingly based on the severity of the individual.
Thank you, Dr.
Thank you, sir.
And we'll move on to some important topic. I think we have a question here. Maybe Dr. Vidya or Dr. Naresh can answer this question. Could the young couple plan for pregnancy at this point of time? Is it safe to plan for pregnancy?
Overall, many pandemics, the academic literature says, has 9 months later, they have found that the birth rates have decreased. This is what the academic literature says. It's probably because of, so I think during this time, if people get pregnant, there will be issues in antenatal visits, etc. So I am not really, and you will also have a decrease in libido and a lot of other social stress issues. So this may not be the right time to get pregnant, although I think we'll have our psychiatrists and gynecologists to comment on the issue. But to also go on to talk about COVID and the effect of COVID on pregnancy, pregnancy is supposed to be a condition where you have a lot, it's supposed to be an immunosuppressive state because of a lot of physiological changes. So, but then COVID virus has not really caused increased mortality in such patients in the studies that I have seen. Although in SARS and MERS, there has been a lot of worse outcomes in pregnancy. It has not really shown that this population has had a lot of mortality. And looking into vertical transmission to the fetuses at this point in time, they have not really found that there have been vertical transmission, but it cannot be ruled out. But because there has been a JAMA publication which has shown elevated IgM level in one of the, I think one neonate which had raised IgM. So that cannot be ruled out. So this is what I have to tell people about COVID and pregnancy.
What about breastfeeding, Dr. Naresh? Is it
breastfeeding? WHO recommends to continue breastfeeding, but the mother, if she is infected, I think essentially she has to take all the safety precautions. At this point of time, there is no recommendation saying that we should not breastfeed the baby, but the mother has to take proper precautions while handling the baby. Because as Dr. Vidya was saying, it's only recently they came up with evidence showing that there can be a transmission, but still overall we don't have very strong evidence saying that the children born are infected. So potentially we have to treat every newborn as non-infective or non-infected, and the mother has to have safety gears before giving direct breastfeeds, or you can give express breast milk.
Thank you, Dr. Naresh. I'm sure this kind of situation, pandemic situation, where people are locked down, sitting at home, they don't know about the future. Maybe we don't know how long it's going to continue, maybe 6 months or 1 year. Even in our country, even if we don't have multiple cases in our country, the issue will not be resolved until the rest of the countries have no cases reported. I'm sure all of you would agree that the situation will get prolonged until we see a definitive decrease in the trend all around the world. Until then, we have to be on the negative side. So I have a question to Dr. Satya. I'm sure you will agree that people are really depressed at this point of time. I'm sure pandemic is a big thing and people are depressed. Some of them might have lost job, or they may be reducing the salary and they are locked down. They are not able to do what they used to do for many years. And then they're not very sure about the future. And then health is another issue. They don't know whether they'll get infected or any of their relatives will get infected. It's a very stressful situation. What will be your advice to tackle or cope up with this kind of situation for a longer duration of time, Dr. Satya?
Satya, can you introduce yourself? I don't think you were introduced properly before. And your voice was not heard either.
Am I audible?
Yeah, you're audible now. Thank you.
Yes. Okay. Yes. Good afternoon. Yes. My name is Satya. I am a consultant psychiatrist. So I'm a general adult consultant. and I work in England. But I've trained in India and in the UK. I live and work in the UK as of now. So as a psychiatrist, I think what we are seeing, and I say this in a very holistic way, is the body and the mind we know are deeply interrelated. So this anxiety is also in a way pandemic, if you see what I mean. So there is a lot of focus on the various things that it's causing to the physical health. So, people are worried that they will fall ill or their children will fall ill, or what is going to happen in the future. So all of this fuels the anxiety because of the uncertainty the world is facing. But through all this, the mental health perspective is often neglected. Because there's a lot of focus on, say, mortality. So, for example, in the UK, every day we get a briefing in the evening by the PM's office or the government about how many people have sadly passed away, which again fuels anxiety. But the mental health is very, very closely related to this. So my advice would be kind of three-pronged, is what we call it as look, listen, and think. So we need to look closely at ourselves as what we are feeling, because a lot of what we feel, the emotions that we feel, which are anxiety, panic, a sense of loss almost, and a sense of loss of control, are normal reactions that people will have when facing a crisis like this. So it's an acute stress response, you might say, a mental stress response, where the body and the mind are trying to figure out, what do I do? What is this new thing? How do I deal with this? So, to use the analogy, it's almost like a fight or flight response is triggered in your mind. So often people can want to shut down, become more panicky. Some people would, if they have the emotional resilience, they start coping. So the advice would be it's almost a common sense approach, is to anticipate what you will be feeling, validate your feelings. We can't ignore anxiety. You can't brush it under the carpet and bury your head in the sand and think, okay, it's going to go away. So to understand that you are feeling like this, and to do all the things that are possible, which are practical and which are pragmatic. So for example, we are all under lockdown. We are in lockdown in the UK. You have children at home. Is to think of yourself working from home, or if you're working as a healthcare professional, think of your role that you're doing. Think of what can be done to maintain both your physical and mental health. So for example, sleep right, exercise right, feed your mind and your body right. So make sure that you are getting some amount of exercise, for your body. Make sure you're getting out, keeping yourself hydrated, keeping yourself positive. And use the one thing we have been kind of focusing everywhere is to use news and to use social media effectively. I know we are using social media now to give information, but what can happen in a situation like this is you are overexposed to a media frenzy. So you hear a lot of negativity, and that can fuel people's worries and has implication on both their mental well-being and also how they feel and how they cope with the stress. The other thing I was quite interested to learn is what did China do, because in a way we have a little bit of the power of hindsight. But apart from the usual coping mechanisms that they have been using, there's not really much of studies that tell us what exactly, but we do know that they have increased reports of anxiety and depression. So the idea is to keep ourselves ready, to acknowledge our fears, and to work through it with a positive approach. That would be my advice.
Yeah, thank you, Dr. Satyam. We might think that the children actually enjoying this holiday, lockdown period. I'm not sure about that, because they're not able to go around, they're not able to see their friends, they're not able to play in their playgrounds. How can you find out children are stressed out or they're depressed? What would you advise to the parents?
I think that's a very, very important thing, because the world as we know it as adults, and the world the children knew as normal, is completely not the same anymore. And this has happened very, very quickly. So just like how we are articulating our fears. We're saying, okay, I feel worried about how I'm getting through this. How I feel, I'm not sure whether I'll make it through this. Even if I make it through this, how will I be financially in 6 months? I don't know. So children react to it in the same way because they are looking at you in a lockdown situation. They are looking at the parents' view and the parents' reaction to this. So a lot of children can feel very stressed themselves, and children's anxieties are also very valid, normal response. So a lot of them can become more withdrawn. They can become a bit more hyperactive. Sometimes the pendulum can swing in either direction. And like what you said, this isn't an enjoyable period. It's not a summer holiday where you go and spend time with your grandparents. It's not a holiday where you're off doing things or playing with cousins or whatever it is. So it's a very difficult situation, and they are reacting to seeing their parents under stress. So they will be stressed, and they can have some behavioral problems. They can become very withdrawn. So I think the advice is, or rather as parents, what I think will be the most effective thing is to have at least a bit of a routine and have a little bit of boundary setting at home. You know, you can't have a situation where you are exposed to screen time 24 or all the time that you are awake. I don't think that is good anyway. I mean, the guidelines from WHO, I remember reading that the lesser the screen time, the better. And have a little bit of routine, and to actually educate your children, but not worry them. And I know it's a fine balance, but don't ignore your child's anxiety, because it's a valid anxiety that they are going to feel as much as you are feeling it. Apart from that, I think there are many practical ways you can, engage them, because you're homeschooling them. You are their parent, you are their friend, you are their mentor, and you are their teacher for this time period. So it's to be a good role model, because in a way children are learning resilience, emotional resilience, and they're looking at your response and how they can respond in a time of crisis. So I think it's an important period to teach them life lessons as well, and keep the positivity intact. That's my view on it.
Thank you. Very, very nicely said. Prof, do you want to add anything on top of what Dr. Satya said in terms of coping up stress, and maybe for the healthcare workers? Because maybe rest of the public, their main concern is staying at home, lockdown, they don't know what to do. But healthcare workers, they have to face patients also. They have to see deaths, and there's a possibility of getting infection from the public also. So they have some additional risk. Prof, what would be your advice to the healthcare workers?
It's very hard, actually, particularly people working in ICU when they see continuously patients not making it. It's a very, very, very tough time. For nurses also, it's a very tough time to look through. I don't know. I think maybe.
Prof, can I just add, from a mental health point of view, I think what you make is a very valid point, because healthcare workers are not just healthcare workers. They are, human beings who are dealing with a disaster. I can't think of a better analogy than that. It is, in a way, there's a lot of focus on their emotional and mental well-being. So, for example, we have a support line that is dedicated to staff, where they can call in, and it is manned by a psychologist or mental health professionals, where they can have a safe space to deal with it. And in the long runs, based on other disaster response kind of patterns that we've seen, it is better to address it, kind of anticipate and deal with it in the short term, because the long term benefits are better. Because a lot of people who are frontline, like what you're suggesting, are going to see themselves going through, seeing a lot of people dying or become really unwell, or even their colleagues become really unwell, and it leads to a lot of kind of post-traumatic stress response. So they become very stressed, and a stressed workforce leads to not a very productive workforce. So in the long run, maybe having a task force or an emotional support helpline available to them, I think will be very useful, both in the short and the long-term perspective.
If I can add something, actually we have a wellness department, which is kind of just dedicated to basically the wellness of staff. And we have regular COVID Zoom meetings also every Wednesday, wherein you can just log in And it's sort of like an Alcohol Anonymous, but for stress. So, you kind of vent all the problems that you have. Some healthcare workers have autistic children whom they have to take care of, and they bring their stress home, and they don't realize that their stress is being transmitted to their husband, to their kids, everything. We all have a baseline level of stress, which we actually transmit to home. So all this is useful to, if you have a group meeting, like a wellness department, you can report your concerns to, you can have regular Zoom meetings with. It actually really helps. And there's also a psychologist on our team. And then we also have some free meditation apps. We have like Headspace, Calm, and so on, which kind of, and they help us. We also have free yoga lessons. And, we have brain yoga lessons, everything which happened in these COVID meetings. And we can easily mimic this in India as well.
I agree. Yeah.
Dinesh. You're not unmuted.
Yeah. I think it's a very valid point, what Dr. Satya has been mentioning. It's just the physical activities as equally important to keep your mind free, because this is a situation, I would say, sitting at home, very claustrophobic. You don't have space to move around. In this situation, it's very important to keep one physically active, because it refreshes your hormones and it makes you feel better.
Yes, sir.
There are a lot of videos online to say how you can do exercise at home. If you can manage an exercise, for half an hour in the morning, half an hour in the evening, I think that is a very good stress buster, actually. And in terms of the way you feel, it will be very refreshing. I can tell from a lot of personal experiences, and it's very easy to do exercise at home. You don't need to run outside. Particularly, this is a lockdown period. I know in the UK, you're allowed at least an hour a day.
An hour.
For physical activity. But again, in India, it's not yet. So I think you can do a lot of exercise at home. It's very easy, very simple. There are very simple exercise. You don't need weights and all. You can use your own physique and the body to do the exercise. I think that's very important. There are a lot of online videos. It's free and they are very simple. If you can do that for half an hour in the morning, and believe me, that's actually very good.
Yeah, I would agree. In fact, there's different types as well. So for people who don't really like to exercise, there are other options. So they can do mindfulness, for example. So there are free apps that allow you to do that. There are very good podcasts or TED Talks that you can listen to. So because through all this, we need to keep what I call a psychological band-aid. We listen to a lot of negativity, and we need to have a sense that we will pull through, because I think what Dr. Ilan said, mankind has seen a lot of problems, has seen millions and millions of deaths through it, but we need to keep positivity and hope alive for us to keep going. Otherwise, we can become very bogged down with all the negativity. You switch on the news and you see, there are, I don't know, millions, 100,000 infected somewhere, some 1,000 people have died, and you hear a lot of that. So in order to keep that, in a sense, you have a sense of, that you will get through this, and you have to carry on through this rather than becoming more unwell and more stressed out. I think it's very important.
Thank you, Dr. for your summary. There is a question for Professor Rela. There are some comments, and there is a question also which just came through. People asked, they felt that the overall mortality because of non-COVID related mortality has come down all over the world. Why is that? Do you think some of them felt that previously patients used to go to the hospital unnecessarily, and then doctors do unnecessary investigations and unnecessary treatment that would have caused more harm to the patients, and then they would have died before, but they are in a safer situation. Some of them, some of the public are feeling that in their mind. What's your view on it, Prof? You're not audible, Prof.
Yeah, now I am. I'm audible now, yeah? I'm not sure if there is actual evidence that the mortality in other patients is actually reduced. We need to look at it. But certainly patients are not coming to hospital. They are coping at home much better than in the days when everything was open. I mean, there may be many reasons for it. I think probably the incidence of illnesses itself may be lower at this time. I mean, when you look at our everyday illnesses, I mean, nowadays I think the focus is on the non-infective problems. Really, the non-communicable diseases are the major killers these days. But the everyday problems, significant amount of them are actually communicable diseases. When you go out and eat, you get your diarrheas. When children go to schools, they come back with respiratory infections. Most of our common day-to-day problem are still probably communicable diseases. Maybe Vidya might say that. And maybe the incidence of these communicable day-to-day illnesses have significantly dropped and patients don't have to go to see doctors. But there is a second issue, really. I mean, in terms of the non-communicable diseases, maybe people's tolerance, even when there are communicable diseases, people's tolerance towards their symptoms is much better, probably. You know, a lot of these illnesses just go off. You might get a little bit of gastritis, and if you are able to tolerate it and sit at home and drink some milk or take some antacids, it might settle. If it doesn't settle in 2 days, you wait for another 2 days. In situations like this, it might settle. Whereas if you go to hospital, you might get an endoscopy within 1 or 2 days by a gastroenterologist. So there may be a slight amount of truth that if you go to hospital, you might get overtreated by all of this. But I think in general terms, maybe even stress-related diseases, myocardial infarctions and chest pain related to going to work and being, very, very stressed in a day-to-day manner, maybe less now. I'm not even sure, but sitting at home is not actually less stressful for these patients. But the illnesses such as cancer, the coronary artery diseases, the liver problems, cirrhosis, I think they will all remain. I think people are just locked up now and putting up with a lot of their symptoms. And I also actually worry that the mortality from these diseases might actually increase when we open. I spoke to one of my friends in the UK who's a surgeon. There, actually, if a patient comes with, who's more than 70, he comes with an obstructed intestinal obstruction, they're told to manage them conservatively because they're worried that if we operate on these 70-year-old for intestinal obstruction, they may need an ICU care and they are reserving the ICU beds for the COVID patients. So the truth may be, if we analyze at the end of all of this, that the mortality of the non-COVID, non-communicable diseases may be higher in the future. Maybe we may be detecting cancers because we are putting off investigations for cancer for 2 months or 3 months, and maybe patients will present at a much later date after everything is actually solved. So I don't think there is evidence that patients are not dying of, the non-COVID patients are not dying, and therefore doctors are over-investigating patients. But I think there may be a true incidence of lower infectivity of the day-to-day illnesses that we suffer, for which we go to our GPs and hospitals on a routine basis. Is there anything else you want to add? I don't know. I'm just rambling a little bit of what's coming to my mind.
I think we have only a few minutes left now. The one more question is, what's the role of plasma transfusion in COVID patients? Who can answer? Dr. Dinesh or Dr. Aishwarya? Could one of you answer? I think there are some evidence coming out in certain part of the world saying that plasma exchange or plasma transfusion might be useful in the COVID patients.
I think, first of all, if you look at the pathogenesis of SARS-CoV infection, it's actually the ACE2 receptors, a lot of data coming on that. It's predominantly present in the endothelial cells. So one of the reasons for cytokine storm is it spreads throughout the body, because if you look at the infection, the time they acquire the infection to the symptom, it's longer. But the time when they get septic and they die, some of them die, that's shorter. So that means the cytokine storm has a major role to play. There are a lot of interleukins, chemokines released from the dying T cells, as well as you see the significant risk factor is low white cell count, particularly lymphocytes. But these lymphocytes are actually hyperactivated. So a lot of cytokine release occurs in patients with severe COVID infection. And also there is monocyte macrophage activation in these patients. That is, all the inflammatory cells are activated, releasing their toxic granules and substances in a very short course of time. So plasma exchange might improve this by removing this sort of toxic substances from the plasma and replacing with a new fresh frozen plasma. But again, it's all sort of anecdotal evidences right now. Most of the treatment for COVID-19 comes from what we're using now, or from the previous SARS infection. So like hydroxychloroquine, all those evidences are from there. So we need a lot of evidence to say this is what probably will help. Because equally, if you look at it, people have used high-dose methylprednisolone, which is also, to reduce the cytokine storm. And again, we need a lot of data on all those newer therapies. Maybe Aishwarya can add that here.
Okay, as Sir said, yes, the cytokine storm, the ARDS pattern in SARS-CoV-2 is different when compared to the other ARDS patterns is only because of two things. One is there is a direct destruction of the pneumocytes, because as said before, these ACE2 inhibitors, ACE2 can attract the SARS-CoV into the pneumocytes. So there is a destruction of the alveoli. So there is a direct destruction of alveoli. So the cytokine storm and the alveolar destruction happens at a very early stage, and from there these alveoli change and the destruction changes into a hyaline membrane at a very, very early stage. So that's why when a patient goes into a state of SARI, that is severe acute respiratory illness, from there the patient getting into a ventilator and then developing very severe ARDS and the mortality rate becoming higher is all because of these patterns. That's why, though there is a contraindication for the use of steroids in patients because the viral replications are higher, they also suggest when the patient is going into a state of severe respiratory illness that is at an early stage of an ARDS, it is always better to add a short dose of steroids as well, apply this plasma exchange into these patients as well. They recommend that early intubations also help in patients who are getting into an early ARDS stage, and an early prone positioning will also help these patients. So these are all from, as Sir said, these are all from data from the other parts of the world where they say that these things will help on these patients, low steroid administration as well as plasma exchange.
Yeah, I think I just want to make one point here. The evidence keep on changing in this disease every day, actually. So every 24 hours, we learn something new. What they said a few days ago was right is becoming wrong now. So whatever, in terms of for the medical professionals, I think it's really important for them to get updated from all these societies or WHO, or they have to go through all these journals very frequently. I think that's a very, very important message for the healthcare professionals. In terms of ventilation strategy, again, what they have told last week has completely changed this week. I think there is something to learn each and every day. It's really important for us to update our knowledge on those aspects. Thank you, Dr. Aishwarya, for updating us. Prof, I think time is running out. Do you want to say something, Prof, so that we can close?
No, I think we should just conclude it. I think it's been very good. It's been very informative for me also. I'm sure many doctors would have benefited from it. And I wanted to keep it simple for the general public also to understand. I think that the times have gone when we think that medical professionals can talk about these things. I think the general public are actually quite literate, and I think they're able to understand how we are thinking as well. That's why I wanted this to be really open to everyone, whoever wanted to listen to it. Some discussions may be a little bit over their head, but I think 90% of the discussions, I think most people who have listened to would have benefited. And thank you, Ellen, for doing a good job. I think I enjoyed the last 2 hours. Thank you.
Any other panelists, any other comments? So I just want to conclude. Thank you all. Sorry, Aishwarya, you want to say something?
Just one short point, sir. I've been getting a lot of calls from my patients who are severe asthmatics and COPDs who are on NIVs and oxygen and who are on steroids and inhalers. That can this be used because steroids are being contraindicated and NIVs are contraindicated in patients is what the public has been getting comments about. So the societies have clearly told the asthma and the COPD societies all over the world not to stop their medications. In fact, it is very important for them to not get exacerbations during this time. Yes, there are higher risk patients, but they should continue the oral steroids which is prescribed to them. As Dr. Dinesh Uthimani said, even for lower patients, the immunosuppressants should be continued. Likewise, they should also continue their NIVs. They should also continue their oxygen therapies and inhalers. As well, one small thing for these patients is as long as this pandemic is existing, if there is any unavoidable air travel or unavoidable travel, they can do that. Otherwise, it's always better for them to stay indoors even after the lockdown period is over. It is mandatory for them to wear an N95 at all times.
Thank you, Dr. Aishwarya. So I'm sure all of us will agree that this pandemic in this century, it will carry on for a longer period of time. I'm sure all of you will agree that maybe 6 months or a year. So the public should understand that it's a long-term issue. It's not a short-term problem. And they should prepare themselves to cope up with the stress, depression. I'm sure at some form, all of us will get affected. Financially or professionally or in some form, all of us will get affected. And I think we have to prepare ourselves, our mind and our body, we have to prepare ourselves to face this situation. I just want to convey only one message to the healthcare professionals. In pandemic, there is no emergency. So please don't jump into patient care. I think it's really important that healthcare workers wear proper PPE. If the PPE is not available, I request don't approach a COVID suspected or COVID positive patients. I think it's really important for us to protect the healthcare workers at this point of time, because in our country, there are very, very limited experts available. I think we have to protect them. I'm not saying that don't look after the patient. We have to stock enough PPEs from now on, and then get trained to use those PPEs, and then ensure that you wear proper PPEs before seeing any of this COVID suspected or COVID positive patients. If there are
can I just
yes,
you
Prof.
mentioned about the protracted nature of this pandemic. I just want to remind people that the 1918 pandemic lasted for 1.5 years and killed 1.5 crore Indian people. 1.5 crore is what it killed.
Yeah.
The only difference between then and now is the possibility of vaccination. So if vaccinations, effective vaccinations come, maybe we won't have such a protracted
even people are
pandemic. And I hope that
people say that it will take at least a year to get the vaccination.
it'll take 6 months, 1 year.
Yeah, that's true.
There is one vaccine which is, sorry, there's currently a vaccine which is under trial in Cambridge in Massachusetts, but they have FDA approval only released for January of next year. And the other thing is, my major advice to all healthcare workers is when you get an N95, have an N95 fit tested for you, right? Not all N95s are protective, depending on how they fit your face. So you got to get yourself fit tested. About 40% of healthcare workers in our hospital fail their fit test, or they needed different types of N95s or PAPRs or NAPRs. So please make sure that you get your N95 fit tested before you continuously use it. Otherwise, there's still a risk of infection.
Yeah, thank you, Dr. Lalitha. I'm sure most of you agree that a lot of hospitals have started online consultation in our country recently. In the last 1 week, even our hospital has started. Whenever you have any symptoms, please call the doctors and consult with them through online. If there is any requirement, you can visit the hospitals. Otherwise, better to stay at home, get teleconsultation until the issue is over. Can we close it, Prof?
Yes, thank you. Thank you.
Thank you all. Thank you all viewers for watching us, and thank you all the panelists to joining us. Thank you. Thank you all. Bye-bye.
Thank you.